Our first speaker this afternoon is going to be Deputy Assistant Director of Medical Affairs, Dr. Paul Cordts. Welcome to the stage.
Okay, thank you all very much. How's my audio? Sounds good. All right, Mr. Flanders, I appreciate the invitation to come to the meeting here. I always enjoy coming to the meeting and talking to you all about topics from our perspective in medical affairs. So this is the agenda. I'm going to start with cancer screening here. I know that topic can be kind of mundane a little bit, but I want to talk to you about where we are with cancer screening. I remember, I'll just tell a little story. I remember the day they turned on CHCS-2 at Tripler, and Captain Jeffries was the deputy commander. Now retired Admiral Jeffries was the deputy commander. We marched right up to his office and said, "Sir, we're not using this electronic health record." No training, and I'm not sure how he felt about that. I also remember the day we turned on Alta, and with the promise that we could do population health management. I actually think we're getting very close to be able to manage our populations now with our new electronic health record, so very excited about that. I'm going to talk to you about patient portals, some of our treatment work, and sort of give you some data on some of the projects we're working on in medical affairs. This is me. These are our learning objectives. You know, back on cancer screening, I really feel like for our healthcare system, it should be one of our core competencies. We should do this well. This should be like clockwork. And we shouldn't have to give it a second thought. Our electronic health records should help us. But I'm going to show you where we are with some of our cancer screenings right now and see what you think about some of the data. So some folks will say to me, "Hey, why are we working on cancer? You know, we have a young, healthy, active duty population." Well, there is an incidence of cancer among active duty service members. And certainly families, retirees like me, their family members, and are over 65. You can see there, if you just cut that line off at the 31 to 40, cervical cancer, 83 per 100,000 DHA beneficiaries. And then, of course, as you get older, the incidence gets higher. So we do have cancer in our system. I'm going to show you some slides on that. But the other thing I wanted to point out, if you go down to that bottom row, USPSTF, Preventive Services Task Force, the ages at which we begin screening are going down. So breast cancer is now at age 40 when they recommend screening. And if you move over there under colorectal cancer, it's age 45. So we're seeing these cancers in younger populations. And so I'm just going to talk to you about these four types of cancer and where we are. This is where we are with breast cancer. And the black line is us, our enterprise. And the yellow line is the HITS 50th percentile. The green line is 75th, and the blue line up top is HITS 90th percentile. So as a healthcare system, we're right at the HITS, we're less than the HITS 50th percentile right now. Now, why is that? One is data completeness. In order to have an accurate denominator, I've got to have data from direct care, private sector care, the VA, other health insurance, CMS. I've got to have the Genesis data from the VA right now, which we don't get. So I've got to have a complete denominator here in order to be sure the data are as accurate as they can possibly be, in order to focus our improvement projects on improving our rate of breast cancer screening. In order to get from that black line at the bottom to over the blue line, the 90th percentile, we need to screen 13,000 more beneficiaries. So that's the gap. And the denominator here is 126,000. Let's go to cervical cancer. How are we doing? The black line. Cervical cancer in our healthcare system, we are less than the HITS 50th percentile right now. Now, that doesn't mean there aren't networks and MTFs that are knocking this out of the park. There are. But screening begins at age 21. And the denominator here is much higher than breast cancer. It's about 465,000 patients in the denominator. All right? And so I think as a healthcare system, our goal ought to be excellence, and our goal for this cancer, like the others, ought to be greater than the HITS 90th percentile. I just think we should adopt that as a goal. I will point out some excitement here. I'm going to show you some colorectal cancer data here, but they now make a vaginal swab that can test for human papillomavirus, HPV. Now, right now, you have to come in the lab to get that done. But the day is going to come very, very shortly where those specimens can be collected at home with a vaginal swab, submitted to the lab, and then you've done your cervical cancer testing. And so we're very much looking forward to that day and to be able to have our patients do self-collection for cervical cancer. And then here's colorectal cancer. Now this is interesting. Look at that little bump up there in about July of 23. That's when we got the VA claims data. That's why getting all the data is so important to us. But look at this one, that black line. For colorectal cancer, we're over HITS 90th percentile right now. So I showed you breast under 50th, I showed you cervical under 50th, and now I'm showing you colorectal cancer where we're over the HITS 90th percentile. And so I talked about having a complete data set, same is true here. And I'm going to talk to you about a couple of other things here, but so we have some differences in the rate with which we screen for these various cancers. So this is pretty exciting right now. You know, we've been talking about HITS measures for 20 years. I was talking about it when I was at OTSG in 2005. And we have not yet, as a healthcare system, cracked this nut on this basic cancer screening, but we're getting close. I feel like we're getting close. Now look at this project that we're doing. These are the FIT tests, fecal immunochemical tests. These are the tests that we mail to your home. All right, Kaiser's been doing this for a while. The VA's been doing this. This is for average risk unscreened patients, not for me. I had a big polyp that got removed a few years ago, so I'm not at average risk. I need a colonoscopy every 5 years, okay? Not for me. But if you're at average risk, we will mail the FIT test to your home. You will collect the specimen, you'll mail it to a lab. We send it to Wright-Patterson. They all go to one lab in the DoD at Wright-Patterson. And then we will run the test. So to date, that second bullet there, we have mailed over 33,000 FIT tests to your homes. And if you look at the data between January and March of 25, we've had about 29% of those kits returned. Now, the Kaiser was able to get the return rate up to 40 to 50%. We're at 29% right now, so we could be doing better. And then of the about 5,000 tests that were returned, about 3.3% were positive. So we had positive tests on about 170 patients right now. So those 170 patients get contacted, all right, and they get offered a colonoscopy. And this is kind of interesting. Some people, they're squeamish about the colonoscopy for understandable reasons. I don't really want to go in. They do the FIT test, it's positive, they go, okay, I better go in. My test is positive, I need a colonoscopy, then they're more willing to go in, and we've got several stories like that. And in a mature end state, next year, we intend to mail about 140,000 FIT tests a year. Next year, we will mail 140,000. And then you have to do this every year. If you're enrolled in Kaiser, you get your test in the mail every year. You collect the specimen, you submit it, the report comes back in the portal so you can see it. It goes back to your primary care provider. So that's what we're doing here when it comes to colorectal cancer screening. Now let's talk about lung cancer for a second. Preventive Services Task Force recommends an annual low-dose CT if you are at high risk of developing lung cancer. You can sit right there on your phone right now and you can go to the American Lung Association and find out if you're a candidate for low-dose CT. Just go to the American Lung Association, you can find out. Simple. There's 3 questions you have to answer. Did you ever smoke? Are you currently or former a smoker? If yes, how many pack years did you smoke and when did you quit? If you answer those 3 questions, the system will tell you whether you're a candidate for low-dose CT. It's simple, but it's getting the questions to the patients, all right, and having them answer the question. These low-dose CTs have no contrast. There's no contrast, so there's no risk of an allergic reaction from contrast. You just go in the tube, they do the low-dose CT. If they see something, they then talk to you about biopsy and any further treatment you might need. But go to the second one, this thing with asynchronous messaging. We're not doing this right now. I think we need to be doing this, all right? But the idea is we push the screening questions to the patients. Right now, we have to do it by text. We have to make a phone call. We have to send them an email. We want to push it in the portal, and we want them to answer it in the portal. And we want the answers to go into the electronic health record from the portal. That's what we'd like to see. But if you answer the 3 questions, the system says you're a candidate. Do you want to talk to somebody about that or not? If you don't want to talk to somebody, here's the number you call to schedule your low-dose CT. We could actually save more lives by screening for lung cancer, perhaps, than breast cancer. But you got to get the questions to the patients. And right now, Murtha Cancer Center doesn't have access to all of the eligible patients across the military health system. So we want to work on that. And that third one I saw last week, where Sutter Health mentioned they had doubled their rate of early-stage lung cancer diagnosis using an AI-powered tracking tool in Epic, so that 70% of their lung cancers are stage 1 and stage 2. Stage 1 and stage 2 are potentially curable. That's when you want to be diagnosed with lung cancer. Okay, so, and I talked to Murtha Cancer Center. We're at about 70% right now. The challenge for us is we don't know the entire population. We need to see the entire population and push them the questions. And so it also helps us with incidental findings. I come in, I get a CT or chest x-ray for trauma. I've got some fractured ribs, but I also got a solitary pulmonary nodule that needs to be worked up. AI can help us not forget that we need to work up that nodule. So anyway, this is the story around lung cancer. I think it's very compelling, actually, and so those are the 4 types of cancer I wanted to talk to you about. All right, let's go to a different topic. When you come in and you get a lab or you get a radiology test, a chest x-ray or a CT scan or MRI, when does that information become available to you in the portal? Okay, so if you look at the top bullet here, the 21st Century Cures Act prohibits information blocking, all right, which is any practice of a provider or other actor likely to interfere with patients' access to electronic health information, such as diagnostic results and clinical notes. And there are some exceptions, and there's some big penalties if you don't follow that. But that's what the Cures Act said. So where are we with this? Here's where we are right now. That top bullet is our current state. So right now, when you come in and you have a clinical note by your provider or you have a lab, there's a 36-hour delay in that note being posted for you to see in the portal. And then if you get radiology or pathology tests, there's a 96-hour delay. Now, interestingly, and I think the team worked with Cerner Oracle on this, the COVID-19 results are released immediately. You see those in the portal immediately. So you can configure the software to allow that to happen, but that's where we are right now as a healthcare system. The second bullet is what most major healthcare systems do, which is they release the results immediately. And in some cases, they have selective delays for sensitive tests. The VA is the third bullet. They're similar to us. Whatever we do with release of this information, we have to do it in lockstep with the VA. And the bottom one is interesting. This is from the American Medical Association, but it says here the majority of patients support immediate release of routine test results. However, about 2/3 of patients want to speak with their clinician first before getting life-changing results. So my question for you is, do you want to see the result of the HIV test immediately? Do you want to see the result of the sexually transmitted infection result immediately? Do you want to see the genetic test for Huntington's disease, which is going to tell you what your life expectancy is going to be immediately? Or do you want the clinicians to look at it, or do you want a built-in delay whether you talk to a clinician or not? So that's what we're wrestling with right now. It's pretty interesting, actually. But, and there's pros and cons to immediate release, and there's pros and cons to the delays we have built in. But regardless of what we do, we have to meet the intent of the Cures Act. All right, so that's that topic. I want you to know we were working on that. All right, I'm frequently asked, is the care getting safer as the result of the electronic health record? So here's some interesting data. These are our patient safety reports. You know how you go in the system, you fill out a patient safety report. These are over 5 years of data, dating back to calendar year 20. 5 years of data. And let's just take a look at that. Look at those arrows. Look at those trend lines right there. The first one on the left, incorrect patient. We were about to give a medication to the wrong patient. The second one, the tall bars there, incorrect dose. We were about to give a patient the wrong dose. The third one over, again, the tall bars there, incorrect medication. And the fourth one on the far right, previously unknown or undocumented allergic reaction. So this is a voluntary patient safety reporting system, so it's imperfect in that way. But why are these trend lines trending in the right direction? A decreasing number. And you're talking about thousands. Like you look on the second set of tall bars there, kind of towards the top, that's 70,000 PSRs in 1 quarter. This is not trivial. These are thousands of patient safety reports. So why is this happening? Barcoding is one. Right now, you have achieved over the last 2 years, 95% of the medications dispensed in our hospitals on the med-surg ward, the ICU, or in labor and delivery are barcoded. Okay? So you've achieved that. That's a leapfrog standard. We've also mitigated the workarounds to barcoding. Okay? You can choose not to use barcoding even if you have it available. So we're at over 95% right now. We're doing medication reconciliation. Are we sure Mrs. Jones is on these medications when she gets admitted? We transfer her from med-surg to ICU. Do we do medication reconciliation, make sure we're clear on the meds? And when we discharge the patients, are we clear, and is the patient clear on the medications that we're on? And then the electronic health record, computerized order entry. The fact that we're entering these orders in electronic health record, and then they're subject to the decision support tools in the EHR make the dispensing of medications safer. This is probably the #1 reason for harming patients in a hospital, is a medication error. Okay, so I wanted to work on this back in 2011, 2012 at Fort Campbell. We had barcoding technology, but the system just couldn't support it. And here we are, 14 years later, but now we've got it fully deployed. And now you can see the results of these things reflected in a reduced number of patient safety reports. And this is medication reconciliation. I mentioned that, but if you look at the bottom row there where it says enterprise, 86% of the time we take a medication history. 79% of the time we do medication reconciliation when the patient's admitted to the hospital. 98% of the time we do medication reconciliation when they're discharged. Okay, it's not bad, actually. It's not bad. We could do better, but these are data that come out of Discern, which I'm very happy about to show you that we're pulling these data out of Discern. But this is another reason why the dispensing of medications is getting safer. The other reason back on the barcoding is, and this is the beauty of the data we have access to, is we can actually see the data from the day before. So if I'm a nurse on the med-surg ward, I come in the next day, I can see what percentage of patients on my ward got barcoded the day before. Whoever has data like that? We've never had data from the day before. That is so valuable when you're trying to do improvement work. You can't be looking 6 months in the rearview mirror and work on improving a process without having data from the day before. And so, very valuable. All right, break, different topic. This might be of interest. We are trying to combat antimicrobial resistance due to prescribing antibiotics to patients who don't need them. Okay, so one of our projects right now is on acute bronchitis, infection in the lung, which is usually viral. It's usually viral. The patient doesn't need antibiotics, okay? Now, the family may demand them or the patient may demand them, but they usually don't need it unless they have some comorbidity or something else going on. What I want to point out here is that go to that bottom table. Let's just look at pediatric, that bottommost row. The national prescribing rates of antibiotics for acute bronchitis are 50 to 60%. If you go to our prescribing rates in our clinics, in our hospitals, it's about 14%. Same phenomenon for adult, just above it. So our baseline rate of prescribing antibiotics for probably a viral infection is actually quite a bit better than the national rates. It's amazing. Now we're trying to make it go lower. But anyway, the point is I need to have accurate data now on did the provider, did they or did they not prescribe the antibiotic? Okay, I've got to have that, all right? And I've got to know what patients have acute bronchitis. So I need the numerator and the denominator in order to be able to work on this. And so We're very excited about this. Antimicrobial resistance is important to our healthcare system. Think of Acinetobacter coming from our deployed environments, and what is the rate of antimicrobial resistance. And so this is an interesting project on antimicrobial stewardship. All right, I like this slide too. I call this the watchers. These are the watchers. When we went to Intermountain Health a year or two ago, we went to headquarters in Salt Lake City, and we went up on one of the floors at headquarters, and there was a nurse sitting in front of, I would say, 12 to 14 monitors, monitoring all the high-risk patients across the Intermountain Health healthcare system. If you're high risk, you're being watched by someone sitting at headquarters. So we can do this. We have the technology to do it. One of our medical centers is exploring doing this right now, but we call this the remote attendant capability. But the idea here is that you've got a watcher. The patient puts one leg over the side of the bed. The watcher is calling the nursing station saying, hey, Mrs. Jones has got one leg over the side of the bed. She's about ready to get up. Elderly patient, 85 years old. Please go in and take a look at her. So that's the concept of this. We have the technology to do it. Do we have the will to do it? And so we're very excited about this. And one of the reasons we're going after this is falls leading to a sentinel event are the #1 sentinel event in the military health system right now. I can tell you exactly how many we had last year. And oh, by the way, underneath that number are literally several hundred falls that didn't result in a hip fracture or a subdural hematoma. So falls occur frequently. They usually don't result in a serious event that requires surgery or something of that nature, but sometimes they do. So anything we can do to reduce the risk of a fall, I think, will be valuable. All right. You know, this I've had a long interest in. I'm going to get on to our readmission rate, but right here in those 4 columns are the 4 evidence-based interventions, the things you should do when you're discharging a high-risk patient from the hospital. So the first 3 from the left, you do prior to discharge. The last one on the right, you do after discharge. So prior to discharge, you're supposed to have multidisciplinary rounds. You're supposed to do medication reconciliation. The third column is you're supposed to schedule a follow-up appointment in primary care within 7 days. Okay, and the last one is you're supposed to make a phone call to the patient within 72 hours of discharge. So the question is, are we in fact doing this? The evidence shows that if you do these 4 things, you can drive that readmission rate down very, very low. So one question is, are we doing the 4 things? And the other question is, okay, what is our readmission rate right now? That's why I need you guys to help with the data. So let's go to the first question here. Are we doing the 4 evidence-based interventions that I show you? Well, look at the bottom, the yellow line on the bottom. Follow-up documented, that yellow line. Yes, we're doing it about 3% of the time. Now, this could be a data quality problem, okay? And that's why I need our teams to be looking at this, because it's a data quality issue, or is this a real issue? It's probably a combination of both. Even the top blue line, did we do medication reconciliation at discharge? We're at about 14%. So we're working on this, okay? We're working on this, but we need to have accurate data that reflects what's actually going on. And if the clinical teams aren't doing it, let's get down to the root cause of why aren't they doing it. They've got a lot of things going on a ward when you're discharging a patient. Okay, and if it's not easy, if there's a speed bump, if there's a barrier to accomplishing this, I think you might also have to fuse data from more than one system to get these 4 data points. But we got to have these 4 data points in order to manage these readmissions. And here's where we are. You don't have to read the fine print there exactly, but on the right there, you see we're in yellow. Right now, when it comes to readmissions, we're between the 50th and 75th percentiles. And so they calculate something here called an observed to expected rate of unplanned acute readmissions within 30 days. So we know how many readmissions we have. The tool lets us calculate how many we were expected to have, and we can see how we're doing then against the benchmark. So right now we're in amber there. We're 50th to 75th. Lower is better. We'd like to get down below that lowest most dotted line there, the blue line. All right, but we got some work to do on readmissions. I think that's an interesting data point. And then I want to show you 2 slides on this. I know I tend to show this as a surgeon, but you know, this is our National Surgical Quality Improvement Program. And each of these dots on this slide is one of our MTFs. And all of our hospitals participate. Where you want to be is toward the left of that chart. You want to be in the green columns, okay? This is comparing our data to the 600 or 700 hospitals that participate in this national database. You want to be in the green on the left. You can see we have some hospitals in the red on the right. I know who they are. The phenomenon here is unwarranted variation. For almost any measure you look at, there's variation. We have hospitals that are among the best in the nation on the left, and we have hospitals that are more than 2 standard deviations worse than the national benchmark. So I just show this just to illustrate this point, but I want to make one other point here on this. This is the graph that comes with it. This came last month in July. Let me make a couple points on this. The data lag. These are data from calendar year 24 that we got in July of 25. Okay, we cannot do improvement work with data lags of 6 or 7 months. We have to be able to see data from the day before, at a maximum the month before, but the only way to do improvement work is to have real-time data. And right now the teams are working on reducing post-operative urinary tract infection and post-operative wound infections. But I gotta have real-time data in order to do improvement work. Now there is a way to get access to those data. And they do have access to it through the American College of Surgeons right now. But, you know, we could even collect these data. Why couldn't we collect these data on complications associated with surgery? So that's one point I wanted to make. The second column there where it says total cases, look at those numbers, 38,000. These are your surgical clinical reviewers that are manually abstracting our medical records right now. 38,000 of them in calendar year 24. And that's a fraction of the number of records out there. You have to abstract about 20%. That is a fraction of the number of records out there. But think of the manual labor required to go in the electronic health record and abstract those data. And we have abstractors that do it. They can access the medical records remotely. But can we move to a day when we don't need manual abstraction? We no longer need manual abstraction. This isn't the only quality measure with manual abstraction. Okay, so this is very labor intensive, but what can we do to move towards what I call, or what's called ECQM, electronically capturing the clinical quality management measures? What can we do? We've got to move in that direction to capture these data fields from the electronic health record. And I know there'll be conversations about coding accuracy and all that sort of stuff, but I do believe we need to move in that direction. And then, you know, people will say to me, well, you know, hey, you know, we're spending a lot of money on this clip here. Show me the beef. What is the benefit of participating in a database like this? And so I'm just going to go to the bottom row there, needs improvement. At our baseline in 2014, some of you may have been here like me for the 90-day review. At our baseline, 47% of the 17 MTFs that were participating in NSQIP at that time were in the needs improvement category for overall morbidity, all the complications associated with surgery, 47%. And then you look on the right where it says 2024, 43 hospitals participating. Now we have 5% of our hospitals in the needs improvement category. That's very, very good improvement. And I know exactly who they are. And if they're in that category, they get a memo from me every year. I don't know if that helps. But you know, that's just get out of needs improvement. If you look at the top row, that's exemplary. And we like to get as many hospitals in the exemplary column as we can every year also. And we're kind of down on that. But the point is, staring at variation in surgical quality does not equate with improving and sustaining that improvement over long periods of time. All right, we've been staring at these data for a long time. We spend money to participate in these quality registries. There's a whole bunch of them. But you know, it requires improvement work, and it requires having data from the day before, or as close to real time as possible. All right, let me show you one more topic here. and then I'll take some questions. You know that we participate in Leapfrog. These are some of the measures in Leapfrog. If you look at that right table there, many of these are dependent on you and the quality of our electronic health record and the decision support tools, but computerized physician order entry, we can measure that. Barcoding we talked about. Hand hygiene. We weren't doing very well. This is basic, did you wash your hands? Did you wash your hands before you went in the patient's room and when you came out? All right, now, I generally think we do that. I think we do it. We weren't measuring it. You have to do a certain number of measurements every month, okay? So we have to have a way of measuring it, all right? You have to measure it, and so, but if you can help us with that, there are some ways to do it. And then down below there, healthcare-associated infections has some measures, hospital-acquired infections. That's an interesting category. I come in the hospital, and I contract an infection as the result of coming in the hospital. Okay, that should be pretty low. Okay, I shouldn't come in the hospital and get an infection because I came in the hospital. And then that bottom one has 10 measures. That's called PSI 90. Those are patient safety indicators. There's a whole bunch of them, 10 of them. I need to be able to measure those. Okay, I need to know where we are on those. And, but anyway, these are the things that contribute to the safety grades. You can see down there, A, B, C, D, F. Okay, how do we do as a healthcare system? Look at the table on the top. In the spring, our hospitals that have enough data have their safety grade posted on Leapfrog's public website. If you go to leapfrog.org right now, you can see what the safety grade is of the hospital where you receive your care. I'm enrolled at AT Augusta. I can go right there in 10 seconds and see what their grade is of an A. Okay, so, but that's how we did. Now look at that first column there where it says A. In the spring, 73% of our 22 hospitals got us overall hospital safety grade of an A. And when you look at the most recent data, the bottom row at the national level in the fall of 24, 32% got an A. That's pretty darn good. Now, it's not all about the grade. It's about those measures I just showed you and working on those things right there. But look at that, 73% compared to the national percentage of 32%. And oh, by the way, Leapfrog agreed to let us do safety grades for our OCONUS hospitals. Some of them did very, very well. Guam got an A. Okay, Naval Hospital, Guam. So it is possible. First time they've ever allowed that to occur. We said, hey, could our overseas hospitals participate? It took us a little while. They finally said yes, and so they got some grades. So that's pretty interesting. But my point here is, as a healthcare system, we do extraordinarily well on Leapfrog. I get asked about this too. Hey, why are we participating? Did someone direct us to participate? No. Admiral Bono got up on the stage one year, 3 or 4 years ago, and announced that we were going to participate. Took us 2 or 3 years to get the data right so that we could submit the data so that we could participate. And then down at the bottom of the slide too, I find this interesting also. Bain-Jones Community Hospital, named one of the top rural hospitals in America, one of 15. They're not naming 100 hospitals, they named 15. Bain-Jones was one of them. Oh, by the way, Bain-Jones, 3rd year in a row. That's pretty interesting, and the only top hospital award in Louisiana. And then the one down at the bottom, Bassett, a little bit different category, general hospitals, but it was one of 36 general hospitals in the nation to get a top hospital award and the only one in the state of Alaska. So the measures for community hospitals, I think most of Leapfrog is focused on our inpatient facilities, our bigger facilities with more complex care, perhaps higher volume, but our community hospitals can perform extraordinarily well. They can perform extraordinarily well. I'll tell you, just working the last couple of days on the consent form, informed consent. One of Leapfrog's standards is that your informed consent form is written at the 6th grade level. So where do we stand as a healthcare system? Many of our informed consents are written at the 12th grade level or higher right now. So the standardization of electronic informed consent is very important to us. Not because it is what it is, it's because we want, to the best of our ability, to make sure our patients understand the procedure that's being proposed. And if the consent form helps, it helps. You have to do it, but we want our patients to understand what we're proposing be done with them. So, but anyway, the point here is we do very well on Leapfrog. I know it's work. If you're an MTF, it's work. It takes work to do this. I'm trying to offload as much as you can for our IT folks. As much as we can offload this work from the MTFs, pull the data, feed it back to them and have them validate the data, which I think is an important step, at least at this point, so that they're not having to pull it. And so I think that should be one of our goals at Leapfrog. Otherwise, if you're a community hospital like Bain Jones or Bassett, it can be a heavy lift at that local level. So we're trying to offload them, and anything you can do to help with that would be important. So this is a little bit of a summary. As I said, on the cancer screening that I showed you, we've been kind of static for 20 years. Okay, but is cancer screening a core competency, or care of chronic disease a core competency of our healthcare system? I believe it should be. But something's got to change. We can't keep saying, well, if we had more population health nurses, you know, and they went into the action list in CarePoint and they just start calling all these patients, we're going to get up over HEDIS 90th percentile. Necessary, probably, but not sufficient to move our healthcare system to a band of excellence over the 90th percentile. And so I think we need this asynchronous messaging, and we need probably some element of AI. It's not easy to tell in some cases if the patient has had the screening. You'd think it might be easy. Oh, it's in this one queryable data field, no problem. It's not that easy. And we need complete data sets. We got to be able to see all of our patients. Got to see all of them. A lot of them had care at the VA or in private sector. Got to see all that data. It's got to come into queryable data fields so that we can put it in the numerator. I think we're better at breast cancer and cervical cancer than is reflected in the data right now. Maybe a lot better. I can't tell you how much it contributes to the gap we have right now, but it's a contributor, and I think it's probably a big one. The clinical decision support tools I mentioned there are making the care safer. I will say we did look at alerts one time, the frequency of getting alerts. Our clinicians get a lot of alerts. The pharmacists, the nurses, the providers, the physicians, nurse practitioners, they get about 250 alerts a month. Okay? And last time I looked at that, the alert response rate was about 6%. Now, we're not unique in that way. Other healthcare systems are the same way, but getting some more sophistication around, hey, what are the appropriate alerts? What are the most meaningful alerts that our clinical teams can respond to and should respond to? Or are hardwired in a way that they don't have a choice. They will dispense naloxone if you're on an opioid. You can configure the system to do that, I think. And so we got to decide what we do with alerts. And then the bottom one here, clinical practice guidelines are interesting. You know, we got about 26 or 27 of these VA DOD clinical practice guidelines right now. And those are hardcore, evidence-based. This is what you should do when you see a patient who's suicidal, who has low back pain, who's depressed, whatever the case may be. It takes them about 12 to 18 months to build them, but they're out there right now. But we have stepped into hardwiring them in the electronic health record. Okay, so I think that's good, as long as it's hardwired in a way that the clinical teams will use them. So we did some experimentation on that. We said, okay, child comes in with asthma. Did we do an asthma action plan? We can actually measure whether we did that or not. Now, I think the majority of time we do it. But at our first blush, did we do an asthma action plan? The answer was yes, about 4% of the time. Now, I think it's a lot higher than that. I think we consistently do it, to be honest with you. But it's not being captured in a queryable data field that we can get into the numerator. So this has been one of our biggest gaps, compliance with the clinical practice guidelines, the clinical support protocols used by the medics and the nurses. We need to be able to measure adherence to these protocols, compliance to the protocols. I think it's a gap, but with the data we have access to, we're beginning to be able to measure it, and I think we're going to be able to close that gap pretty rapidly. So that's what I have, and I'm open to any questions you might have.
Never fail to disappoint.
Okay, Charlene,
I have
shoot.
3. are we tracking how leapfrog scores are driving beneficiaries back to us? I know as a consumer, that's important to me. If you're safer than someone else, I want to come to you.
All right, let me start with that one, Sherilyn, before you go on to your next 2 or 3. No, I would say no. But when we started into Leapfrog, there was concern about that, right? Our hospital would get a grade of a C. The hospital outside the gate would get a grade of an A, and the patient would walk in the director's, commander's office and say, I'd really rather receive my obstetric care in the civilian hospital that gets a Leapfrog grade of an A. Now, I've not heard of anecdotes of patients doing that. If you're a patient, I don't know. The goal with the transparency is to have the data be useful and user-friendly. And even with Leapfrog, how often do you all actually go and look at the safety grade from Leapfrog and decide, well, I'm going to go to hospital A instead of hospital B? Frankly, I don't think that happens very often. It should. I think that's a challenge for us, but it's making the data available in a way that I can decide where I want to get my hip replacement. Okay, and so if you're a patient, you want to know what are the outcomes for that surgeon and what is the infection rate for that hospital. You want provider level data and you want hospital level data. And as a patient, you should be armed with that information and be able to make a very deliberate decision about where you get your hip replacement, your knee replacement, resection of your pancreas, if you've got pancreatic cancer, esophageal cancer, whatever the case may be. You're going in, you're having a mitral valve replacement. You ought to know the outcomes from that surgeon and that hospital around mitral valve replacement. And so I don't think just systematically we're there yet, but that's the kind of information patients should have access to, my view.
I'm that patient that looked, and that's
Okay.
why I went to Walter Reed, and they saved my life. My other question is, with your fit testing, the projection in 5 years is that we may be able to save the organization $450 million over the FIDEP. Are you guys going to get it back to be able to do more great, wonderful things like fit testing? Or are they? I'm just asking.
No, I don't know that we'll get it back. But what's interesting on the fit testing, when we looked at the baseline, when we were doing colon cancer screening, 99% of the screening was by colonoscopy. We were hardly using any fit tests or any Cologuard, almost never. And so what was happening was the MTS couldn't keep up with the demand for colonoscopy, so we were sending literally hundreds of colonoscopies to private sector care. Now, when you go with fit testing, it's a commitment, right? Because it's an annual test. Once you start into it, you need to mail the patient their fit test every year. But fit test costs about $20. Okay, compared to the cost and time for the patient of a colonoscopy, and consuming the time of our clinical teams and our healthcare system. So I think it's an interesting question. I'm a believer in it. We think it will reduce some of the healthcare disparities that might be out there right now. And we think it will help mitigate, folks that are like, I'm not really too interested in the bowel prep for my colonoscopy. Okay, but if they get a fit test that's positive, maybe that will persuade them to have a definitive screening test.